Dr. Richardson is our assistant program director. So she really, truly knows the program inside and out. She also hosts coffee hours for students. So if you ever have questions about the program or want to connect with the movers and the shakers of the program, you can go to Dr. Richardson. But today she is going to talk about a little bit about medical family therapy and a biopsychospiritual approach to that. And we're going to leave some time for questions after. So Dr. Richardson, however you want to take it away would be
Yeah.
great.
Well, thanks for having me. I have a little presentation. I couldn't come without a presentation for you. So let me just see if I can get it to go for us. All righty. Okay, are you just seeing the slides, not my fun notes? Okay, perfect.
Just the slide.
Awesome. Well, I am going to move the little picture around. So if something pops up, Dr. Bayman, please feel free to slow me down or stop me if needed. I won't be able to see the chat or anything pop up. So, but for time's sake, I will go ahead and just jump on in. I'm really excited to be here with you all. As Dr. Bayman mentioned, I'm the assistant program director for the Marriage and Family Therapy program. And I've been with Capella for just under 2 years, actually, and have loved my experience, loved being in this leadership role and working with the amazing learners, but also our amazing faculty, as many of you have had exposure to. And as Dr. Bayman said, a small little plug, we do have our coffee breaks tomorrow, actually. So there's 2 sessions. If you want to come chat with Dr. Heenan and I just about the program, give your feedback. We're happy to answer any questions. But for today, yes, I'll talk about medical family therapy and using a biopsychosocial spiritual approach. So to give a little bit of background for those of you who I haven't met with before, prior to coming to Capella, most of my work has been in medical settings. So I've worked in primary care, working alongside family medicine providers. I've worked in specialized treatment facilities, working with patients and families navigating new neurological disorders like brain injuries, stroke, spinal cord injuries. I've led hospice support groups. I've also helped teach within psychiatry programs and working with medical students. But prior to coming to Capella, my most recent experiences were actually being a faculty member with a medical residency. So if you're not familiar with medical training, after med students go through their initial training, then they have to go on and do 3 or 4 years of residency before they go on and get licensed. And so that's where I was serving as a faculty before. So, but as you'll learn throughout today's conversation, my background is in marriage and family therapy, and that's really the roots of MedFT. So you're going to hear me use MedFT for short, just because it's a mouthful. And so my master's and my license is marriage and family therapy, but I wanted to pursue a PhD in medical family therapy. Now, there's not a lot of formal degrees in medical family therapy, but there's trainings, there are some certificates. But what I hope that you all can gain from today's conversation is that you don't have to go on and get a formal degree in medical family therapy to use the key principles and tenets of MedFT and to use a biopsychosocial spiritual perspective. So you all, many of you put your names in the chat, which makes me think many of you are in internship, but if you're not quite, you're going to get there at some point. But many of you are also going to, well, hopefully all of you, going to be looking for employment one day. So I'm also hoping that we can talk a little bit about where MedFTs work. And even if I don't have a formal degree, what are opportunities out there for me if this is kind of a viewpoint or a philosophy that speaks to me, or maybe you just have a particular interest in working in medicine. So we'll go over some definitions and some kind of key foundational pieces of medical family therapy, but then I want to talk a little bit about the ins and out. I've brought a couple sample cases, but then I'm hoping at the end we have a little bit of time to discuss if you all have some cases that might apply really well to the biopsychosocial-spiritual framework. And then, of course, as Dr. Bayman mentioned, we'll try to leave some room for questions. So what is MedFT? So this is a definition that was actually developed by medical family therapists and other experts in the field, if you will. So MFTs as well as medical providers came together and developed this definition. And I want you to hear some of the key pieces. That MedFT is an approach to healthcare sourced from a biopsychosocial, spiritual, and marriage and family therapy, but also informed by systems theory. So the practice of MedFT spans a variety of clinical settings with a strong focus on the relationships of the patient and the collaboration between healthcare providers and the patient. MedFTs are endorsers of patient and family agency or autonomy and facilitators of healthy workplace dynamics. So you can see there that MedFT is really kind of like a branch off of MFT, if you will, with a little bit more specialized focus on that biopsychosocial spiritual model, and particularly within different types of systems. Most of the time, those are medical systems, but it doesn't have to be. And that's what we'll talk a little bit about today. But you hear a lot of the relational piece. One thing is that a lot of times in MedFT, while we may be doing more traditional therapy, just like we do as MFTs, a lot of times we're actually working with the patient. We're kind of working on that relationship between the patient and their healthcare team. So we're a part of that team. We join that system, so their healthcare team, their healthcare system, and help to facilitate change within that. And so sometimes that is between patient and provider. We may be the ones that are helping to raise the voices of patients or help patients advocate for themselves and their care. But sometimes we may be the ones that are also having to kind of motivate or bring the best guidance on their physical or medical care back to the patient. Because we all know sometimes it's not easy to hear information from maybe the healthcare system. So how do we help patients digest that or create change once they have their treatment plan from their medical team? It's very collaborative, which makes us very well equipped as MFTs to do this type of work. And it's a huge piece is being able to help patients and families throughout the change process. In my experiences working in MedFT, it's very rare that there's not an experience of some level of grief or loss at some point throughout the experience. So think about anytime someone receives a new diagnosis, they have an injury or a new illness. There is some type of loss, even if that's an ambiguous loss that happens. And so supporting families and patients through that loss and new meaning-making experiences of what this means for them moving forward and their identity is a big part of this work. You also can see here this concept of agency and communion. If you look up medical family therapy literature, this is two concepts that you'll see. So I mentioned being able to promote autonomy or agency, as we call it, for the patients so that they have a say in their healthcare, but also promoting communion. So we're helping to build the support system around the patient and their family. So that could be their immediate family or maybe their community. Or when we say communion, we also mean building the support team, so their healthcare team as well. So these are just some guiding goals we have for MedFT. So you might be wondering, what's really the differences then? You know, we obviously have this medical component, but what's the differences, but also some similarities between MedFT and marriage and family therapy? Well, as you all know, in MFT, we're looking a lot at family patterns. We're looking at how, even when working with an individual, they are embedded within the different systems and relationships that they are a part of. So even if we're working with one individual, we are constantly thinking about the interpersonal experiences or the systemic relationships that are impacting them. And similarly, we do that in medical family therapy too. But again, we're often using that biopsychosocial spiritual piece on top of that systemic framework. So I know in my training, we didn't talk a lot about health or the physical or the biological wellness piece of someone's experience. And that is something that is heavily emphasized here. But in addition to that, within the patient as a system themselves, which we'll talk about, And in their family systems, a lot of MedFT's work is also about looking at the larger system. So a lot of times that might be the healthcare system. It could even be like a business or a corporation, or a community system. So it's kind of expanding what we know about systems to that even larger, that larger system as well. So I could probably spend my entire presentation just talking about the similarities and differences between traditional therapy and MedFT, but to make it a little bit brief, I think some of the things that stand out initially to me and were my biggest transition, because I did train in a traditional MFT. My internship was at a private practice, so that was the world I knew. And then I shifted into medical family therapy. And when you're working in healthcare, if any of you do or don't have that experience, it is a different culture. There's different languages, there's different priorities, there's different hierarchies. Even advocating for mental health, it sometimes can feel like a heavy lift in the medical world, whereas in our world, that's the norm, right? That's what we're here for. So there's different cultures that you have to consider when doing this type of work, and you have to be able to be adaptable to those cultures. Now, I will say, I think in general, the health field has come a long way of prioritizing mental health and making sure that it is a part of health and well-being. But there's still pieces of that puzzle that are still can be kind of a bit of a uphill battle at times. Also, if you're going to do this type of work, you have to recognize the settings are different, right? If I'm working in true integrated care, I mentioned I've worked in clinics where I was next door to the medical provider. I was working with physical therapists. I might, instead of be doing a nice, comfy, traditional therapy session on a couch with, nice throw pillows and nice artwork on the walls, I might be doing my therapy in an exam room. So it's a little bit more sterile. It's a little bit more cold environment. So it's different. But what's great about that too is it also creates new opportunities for patients, because they're coming in to see their medical provider, but they also get you on top of that. So I like to tell myself I'm a bonus when they come in to their medical care. Time is also very different. The time I spend with patients, and you're even hearing some of that culture, right? That I'm saying patient. I'm very used to that as a MedFT, whereas I probably would have never said patient as in my traditional work as an MFT. But the time is very different. I may only work with a patient or their family for 15, 20 minutes before the provider comes in, maybe after or even with them. Whereas obviously we're very used to the 50 minutes in our traditional therapy, or sometimes even longer. So those are some primary differences, but I think it's important to hear that both MedFT and MFT see mental health as part of health. They both use that systemic and multicultural lens when working with systems, whether that's an individual, a family, or a larger system like the health system. Both understand the importance of collaboration, and then both are trained in that systemic family therapy. So again, there's no license to become a medical family therapist. My license is still MFT. And so there's no specific license that you have to do this work, but it may just be about kind of exposure, training, supervision, and just opportunities for seeking out how you as an MFT could also work in maybe a medical system. So for time's sake, I won't go into too much on theory. I could really, really nerd out on some theory for you today, but I won't do that. But I do just want to highlight that there are three primary theories as a MedFT that we use in guiding our work. The first is systems theory, that hopefully you all are very familiar with, or if you're newer in the program, will become familiar with. The Biopsychosocial-Spiritual framework, where I'm going to spend a little bit of time. And then a third that we call C.J. Peake's three worldview, which for today, I'm not going to go into because that gets a little bit into the weeds and a more on kind of the operational side of MedFT. But as you all know, we still use that systems lens, that when we look at a system, again, whether it's a patient, their family, and the family's experience, or the healthcare system, that a system can be thought of as a set of interacting elements that are constantly changing, just like the gears, right? That we know that by separating or changing a part of one system as a whole can't help but change the entire system, and vice versa. So that is something that we think about and makes us uniquely equipped as MFTs going into this work because we really know how systems work. So whether I'm promoting change at the individual, family, or larger system level, we get systems, we get relationships, we get communication. The second model that I want to spend a little bit of time on before I move on is the biopsychosocial-spiritual framework. Now, this is really about the study of the BPSS influences on the human system. So the biopsychosocial model or BPS model may not be necessarily too new to many of you. In our program, we train learners on how to do a biopsychosocial assessment. But really, this model that we use in MedFT by Engel is really about that highlights the interweaving of what we call the cellular to societal complexities that impact individuals and families and their health. So when I say that, I mean thinking about truly the importance of one's biological, psychological, and social health in everything that we're doing and when we're trying to create change, recognizing that if we're only attending to one of those, we might be missing a big part of the puzzle. However, I will say when I was in my training program, we didn't do a lot of work when it came to the B, right? We knew the P, we knew the first S, the psychosocial was very there, but the B was something we didn't focus too much on. And I think it wasn't until I started to gain more experience in MedFT that I realized, why is it important for me to understand someone's physical health experiences or to ask them about experiences of illness or disability? Why is it important for me to know someone's development history or the experiences they had early on or medications and all of that? And, I think a good example of this is like with trauma work, right? That if we only look at the individual's experience of trauma, we may be looking at these things here at the top of this model that say, maybe that's cultural trauma, right? Maybe that's racism or something that's created from more of a societal piece of trauma. Maybe it's more interpersonal trauma between a peer or a family member towards an individual. But if we only look at those pieces within the person and above, we're missing a lot of these pieces underneath, recognizing that trauma has a physical component to it, right? That early childhood experiences impact an individual's brain development. It impacts their cells, their tissues. It impacts their stress response system so that later in life, how they respond to stress, how they respond to relationships, that's all going to come back up. So even though as an MFT, we don't necessarily always see these lower level pieces, they're really important that we consider. Thinking about even anxiety. I'm sure all of you, if you're in internship, have worked with an individual with anxiety. You may even have experienced it yourself. There's a physical component, right? In the way the body reacts when I'm feeling distressed, when I'm feeling overwhelmed. And so I think that it's really important that we really focus on that biological piece as well in the work that we're doing every day with our clients. To expand on the BPS model, later, some additional researchers included this component of spirituality, which really makes up the BPSS in the MedFT model. And when we think about spirituality, most of the time we think about that in religion, higher power, DD, and it can include that certainly. But when I say spirituality, I want you to think about it more in belief systems and meaning making and how one views the world. I like to ask patients, what fills your cup up? When you're feeling down, you're feeling like, what recharges you? And for some, that might be nature. It might be family. It might be food. It might be spirituality. It might be yoga or mindfulness. And so this is a really important part because these things help us when we're developing a treatment plan. It helps me know, what do we need to lean on in order to help create change? What are their beliefs around health and well-being? Thinking about culture in particular, there are many cultures or communities that have been historically mistreated or hurt from the medical world and even continue to be marginalized. So it's important that I know that as a provider because that's going to impact maybe how their willingness to come into the clinic, right? Their willingness to use, their interest in using medication. They may come from a family or a culture that prefers non-Westernized approaches. It may impact the way that they trust their providers or their willingness to adhere to treatment. So spirituality and how they make meaning of health and well-being is really important part of this model as well. So just to give a little bit of background, I think it's really important, as I mentioned, MedFT really grew out of marriage and family therapy. And when we think about many of the pioneers of MFT, we see a lot of roots in medicine and biological health if we go all the way back. Even thinking about Gregory Bateson and the group that led the Schizophrenia Project in Palo Alto. You know, they didn't believe that families cause schizophrenia, but rather family patterns and family communication led people to a diagnosis because of challenges within interpreting messages and communication. Carl Whitaker, while maybe his approaches may seem a little outside the box for some, he really was one that broke from the psychiatric traditions to experiment with family therapy. And he found it actually important to create stress or create tension, that was necessary for change. And again, stress has that physiological, biological component to it. Even Murray Bowen, he was a trained psychiatrist. He went to med school, you know, so he specialized in schizophrenia, and he really saw that importance of looking at the family system, even hospitalizing whole family members so that we could really see how triangles worked, and working with different subsystems. So really our field came from the medical world. But I think it's important to note that MedFT isn't trying to go back to that medical model, but instead learn how we've grown as a field, and how we now understand systems and families differently, and how can we then go back into the system that families are engaged in at all times. There's always medical things kind of going on. How do we go back into those systems and create change using the things we've learned? Again, whether that's when working with a patient, a family, or maybe even the healthcare system as a whole. One way that we can do this is through integrated behavioral health care. So really, you may have heard the term integrated care, and really that is just the degree of involvement or that sophistication in bringing these two worlds together. So how does the behavioral health professionals and other health professionals collaborate with one another? And this can look a lot of different ways. I won't go into, too much into this chart, but this is a nice little table that talks about different levels of integrated care. So for some of you, you may work at a clinic with mostly all mental health providers, or you may work at a site, or you plan to do private practice with just others from similar disciplines. So maybe you don't often communicate with other health professionals. So that might be seen a little bit more as a level 1 or a level 2. This was my experience too in grad school. I worked at a private practice, like I said. I worked at my program's clinic on campus, so there wasn't a lot of outside collaboration. But at one point in my master's program, I had a client with a traumatic brain injury come in. And I noticed that there were some challenges at times in the way that my client communicated, their memory, and even sometimes just their reactivity. Honestly, that's what they were coming in for, is they got really reactive in some settings outside of therapy, and that's what we were working on. But I didn't know anything about brain injuries at the time. And so I tried to do my own research, but what really came down to create a lot of difference was when I finally decided to collaborate with her doctor. And so it didn't mean that I needed to become an expert in traumatic brain injuries. It didn't mean that I needed to go to med school or read her chart from her doctor. It meant simply getting a release of information from my client and collaborating, calling that doctor up and asking a little bit about her particular injury. What does that mean based on the type of injury she had, for how she communicates or how she responds to stress? What does treatment look like? Or are there any medications I should be aware of, or side effects? And so what was helpful about that is, again, it didn't mean that I was treating the TBI. That's not why she was coming in. But this was an experience that she had, a system experience that she had, that helped me understand, okay, when I'm asking certain questions or I'm implementing certain interventions, these are some things to be aware of. So it just really helps support the treatment process. You can also see as you look at this chart, there's that kind of co-located, that level 3 or 4 collaboration. You may be at a site where you are working on site with other professionals. Maybe there's other therapists like physical therapists or speech therapists at your group practice. Maybe your office is actually in a clinic. Maybe you don't see every patient or you don't always talk to the providers, but there's some level of collaboration. And then the highest level of integrated, that level 5 and level 6, are really those MedFTs or behavioral health providers that are really embedded within that healthcare system. So maybe they're on site, they're in the clinic, they're seeing patients regularly, they're in the team treatment meetings, they're constantly communicating with all of the medical providers. One example of this for me was when I did an internship at an inpatient rehabilitation center for the individuals with brain injuries and spinal cord injuries. They were there for their physical health needs, but obviously these are new injuries. So there's a lot of adjustment that comes with this. A lot of my role was motivating these patients that now had a life-changing injury for them to do their physical therapy. So I was on a team with physical therapists, rehab therapists, speech therapists, occupational therapists, you name it. And so that was true kind of collaboration in a nutshell. So, but I think it's important to note that not every system needs nor desires this level 6 integration. But I think it's really important to note that even if you're in a system that's a little bit lower, or you plan to work in a system that's maybe more on this level 1 or 2, that just at that basic level, collaborating with health professionals or part of an individual's treatment team can be really helpful in helping you move towards goals or helping you have a little bit more of an understanding of the client's experience. So just kind of some examples, if maybe this is something that interests you or you're kind of curious where are these MedFTs at? Really, if you think about any type of setting that there's high levels of collaboration, potential integration, and using that biopsychosocial spiritual approach, there's not a lot of things that wouldn't be on this list. So yes, if you're going more of a medical route, that might be a hospital or a family medicine practice, like a outpatient clinic. But many maybe work in universities, or maybe they're just doing private practice, but they're using this biopsychosocial spiritual lens. They're collaborating with healthcare teams, so they're using more of an approach. Others are in schools. I know many that work in schools. You know, they have an integrated care team of a school nurse. They have their MedFTs on board. They have school psychologists and school counselors on board, so they really work from a multidisciplinary perspective. And I even have numerous colleagues that work for athletic teams and athletic organizations. They're kind of the mental health or the mental performance expert. And so they're alongside all of these other professionals from different disciplines, helping support the athletes within the organization. So lots of different opportunities there. And depending on where you work, your role may look very different. So again, it might not be the traditional 50-minute session. It might, but it may also be more brief. For example, when I'm working in true integrated care, where I'm seeing the patient for 10 or 15 minutes before the provider comes in, I'm using much more of a solution-focused approach, right? It's brief, it's measurable. We can be a little bit more kind of goal-oriented and thinking about kind of behavior changes. As opposed to when I'm doing traditional therapy in my 50 minutes or I'm working with a couple, I'm much more emotionally focused. So those are very different experiences, but it just depends on what the need is in the system. So as a MedFT, I think the biggest thing is that you have to be very adaptable. And then as I mentioned before, sometimes a lot of our role is being that facilitator, either for the patient to the healthcare team or the healthcare team back to the patient and their family, or sometimes even among the healthcare professionals. So sometimes I know relationships, right? As an MFT, I know relationships, I know how to intervene, all of the therapy skills that you all are developing now. I take that into the healthcare or the workplace system and help to create that too. So there's even MedFTs working in different organizations and businesses. So they're not doing therapy, but they're able to use these skills that we all have learned as MFTs to promote change into the larger system as well. We've talked a lot about kind of those tools and those needs that is important as a MedFT, but I think some of the biggest ones are that ability and willingness to collaborate, whether you're in that system and you can pull someone aside in the hallway, or you're working in your own independent practice or at your internship sites, and it's about collaborating by reaching out. Again, getting that release of information and permission from the client, but reaching out. This can actually be really helpful, especially if you have clients with medications that maybe you're unfamiliar with. I'm still very, very unfamiliar with most medications. I didn't go to med school. I didn't go to I didn't go to school to be a pharmacist. And so even collaborating or consulting informally with a pharmacist can be really helpful at times too, to say, what are the side effects? What are some things I might be looking out for? It's also really nice for referral systems, so that if providers want to refer folks to you and you kind of work together in collaboration, or if you might need to refer someone to a provider. So being able to kind of have that open door, that collaboration with different disciplines is really helpful. And I think another important tool that you all can even be implementing into your practice now is that willingness and ability to research an illness, a disability, or disease to become BPSS and socially, culturally informed. And when I say that, I mean, again, I didn't go to med school. I didn't know what initially I was doing with my client who had a traumatic brain injury, but being willing to go and research some of that on your own. Not just relying on supervision always. Obviously, that's a great place to process these things, but going and doing some of that research, learning what is this injury? What are some of the side effects? What is the lifetime experience look like? How does this impact relationships? How does this impact intimacy? Are there different resources available? Are there support groups for the individual or their family? So looking at national organizations for particular diagnosis or illness or condition can be really helpful for this. And then lastly, before we get into some kind of case experiences and hopefully open up some discussion from the group, is that, again, you don't have to go and get formalized training necessarily to become a MedFT, but I think just having this lens can be really helpful, or I don't think, I know that having this lens can be really helpful in the work that you're doing, even at your internships that maybe right now aren't super integrated or don't appear as collaborative. So whether you're bringing this back to your practice, or maybe during the program or after the program, you might be interested in working in a healthcare setting. There's lots of great resources out there. And one of those is actually there's a set of competencies for family therapists like yourself working in healthcare settings that was put out by AAMFT. There's a topical interest group that I'll share at the end that's specifically for family therapists interested in healthcare work. And so that could be a really great resource for you. But the key competencies that have been put out by AAMFT for this are, again, that systems perspective and that understanding of systems theory concepts and ideas, using that biopsychosocial-spiritual framework and approach to attend to wellness and well-being, collaboration with multidisciplinary backgrounds, leadership. I think this is a really important one, and this is more about that integrated or collaborative approach, and how can you be that advocate or that champion within the system to help make these changes or bring this to the system. And so sometimes that's even, you may work in a system that there's not, you may work in a healthcare system that there's not a lot of mental health resources. So you're developing resources, or maybe you're putting on trainings for the healthcare team. Or even within your own systems about how leading the charges to be more collaborative with professionals that are part of your clients' care teams can be a part of this as well. Ethics, of course, is a very important part of this work as a MedFT. We all ascribe to the AAMFT Code of Ethics, which you continue to do that work. But when you're working in those healthcare systems, HIPAA is also going to be a really important guideline that you'll have to attend to. And it does look different. When I'm working in an electronic health record with physical health providers, you know, how I document and how I attend to HIPAA may look a little bit different than when I'm keeping my own therapy notes in my private practice. So those are some things that you have to attend to. It can also be interesting because you're working alongside professionals that have different codes of ethics, like nurses. They have their own code of ethics they attend to. And so that's a big part of this work that is important for a competency. And then lastly, diversity. I mentioned that there's a lot of communities that have been hurt or continue to be marginalized within healthcare settings. So being able to have that multicultural lens and that sensitivity to empathize with patients, but also to help promote change within the healthcare system or the different systems that you're a part of when it comes to diversity, equity, and inclusion is an important part of this work as well. So what I'd like to do, if it's okay with you all, and I don't know if it's just easy to come off mute whenever I bring this up. I can't see you all very well, so please feel free to engage. But I just brought like a simple case that if you were working in an integrated care site, so say you worked you worked at a medical site with some family doctors, right? Or some nurse practitioner, the patient's coming in to see their health professional. But here I come in to do my assessments and as part of their care team as well. So what I'm going to read this out loud, but what I'd like you all to just think about are what are some of the biopsychosocial spiritual pieces that you are seeing in this? And how might you use your systemic lens to support this patient, but also support the provider who's working with this patient? So threefold there. So PK is a 46-year-old Latina woman. She's a wife, daughter, sister, and mother of 4. She presents to her primary care provider at the local clinic for a routine visit and a refill on her medications. She has a diagnosis of hypertension and type 2 diabetes, which her doctor reports is currently, quote unquote, uncontrolled. PK is 5'4", she's 232 pounds. You screen for anxiety and depression, just as you do for all your patients, and she has a GAD-7 score, which is an anxiety assessment of 9 out of 21, which indicates about a moderate report on anxiety symptoms, and a PHQ-9, which is a depression screener, of 3 out of 27, which is a low reports of depressive symptoms. PK is a stay-at-home mom. Her mother also lives in the family home, and her husband works 2 jobs to, as she reports, to help make ends meet. So, this is a great time to just kind of consult on this case, but what are some of the biopsychosocial spiritual as well as systemic things that are standing out to you regarding PK's experience?
Maybe stress seems to
Okay.
be, I mean, if it's just moderate anxiety and then the depression's on the low side. If her mom's living at home, she's obviously has that stressor, and then her husband has to work 2 jobs, but she's at home all the time. So I would say stress is a big factor in her life, which can cause issues with hypertension. And
Right.
you can eat more sugar for comfort, possibly emotional eater.
Awesome. Awesome, Chastity. Thank you for that. So to kind of summarize that, stress may be something I want to check in about, right? She's got a lot of family dynamic pieces that mom lives at home. There may be some caretaking or maybe some stress. Who knows what that relationship looks like, right? She's a mom. She's got lots of kiddos at home. Husband's working 2 jobs. So there's likely some stress there if that need is there. As you mentioned, she has some anxiety and depressive symptoms, but because these are just screeners, we definitely want to learn a little bit more about that. So asking about stress is a great question. And I love how you brought in that biological piece, right? That said that stress can raise someone's blood pressure and can impact hypertension. It also could impact their eating habits. And so that could impact diabetes as well. So great thoughts. Other things that you all are seeing in this case from a biopsychosocial spiritual perspective?
She is oh, sorry, my video's not on. She does come from a Latina background. As someone who is Latina, you know, having my mom live in my home wouldn't be uncommon. My tia actually lives in our home. Having multiple kids is not uncommon for my culture and my people.
Right.
I actually have hypertension myself, so it's likely caused by her diabetes. But when the doctor says uncontrolled, that might be an inappropriate way to like phrase that. She's clearly coming in for a routine visit. She's refilling her medications, which means she's on a plan. She has a plan. She's doing her due diligence and going and getting her prescriptions refilled. Though she's scoring moderate for anxiety, she's low on depression. So yeah, you might want to ask a little bit more where that anxiety is coming from. But clearly she's like the person, the caretaker of not only her mother but her children. I'm sure there's just normal stress that is being a mom. I'm a mom, and having one kid's enough. I couldn't imagine four,
Sure.
and my mom
Right.
and my husband's constantly gone, right? All of those could cause her to be moderate. So I wouldn't be super concerned, but I would definitely want to press a little more like, is there any more support systems we could give you? Like, what's the best course of action to, you know, give you resources to for that doctor, right? Why does he feel it is uncontrolled? Is the medications not enough? Does he feel that there's more that has to happen there to feel like she's controlling it? So I definitely think I would look at those things.
Yeah, Darby, thank you so much. And thank you for sharing your experience with this. I think you hit on some really important pieces, especially related to culture, right? There are some pieces of this that maybe the provider feels like this is a lot, but maybe this is, like you said, fairly normative in this patient's experience and in their culture. And so I think I love how you said, you know, this is pretty typical, right? So I think being able to even empathize with the patient to say, you got a lot on your plate, right? Like this is a lot. So let's, you know, your health is still important. Let's talk about that, right? Of how can we bring in some of these support systems? I think that's a beautiful way to approach that. I also appreciated your how you highlighted that uncontrolled. That is sometimes language that gets put out. We also sometimes in the medical field may hear that someone is not adhering to treatment, they're not compliant. So sometimes, like you said, that can feel very harsh. So being able to dive into that and both maybe ask the doctor, when you say uncontrolled, can you tell me a little bit more about what that means? But also having that conversation with the patient and saying, you know, your doctor has mentioned that your sugar numbers have been a little bit high lately or kind of a little bit all over the place. Can you tell me a little bit more about that? So to not jump to a shaming, blaming place, but to be able to invite that conversation. You mentioned culture, and I think that's a really important for any of the work that we're doing is that when it comes to diabetes, especially that and hypertension, some of this could be hereditary, right? So learning a little bit about that and what that means, thinking about the spirituality piece of how does she make meaning of that if this is something that is a part of her family's experience. I think it can also be really important to ask about what does food look like and mean to you and your family? Because oftentimes with diabetes, there's medication management. There can be lifestyle management depending on the severity. But within particular cultures, food means something, right? Sitting around the table means something. The types of food within her culture, maybe a higher carbohydrate diet is pretty typical. Maybe even fruits are very typical, but she doesn't recognize that certain fruits may be really high in sugar or carbohydrates. And so just being able to learn a little bit about how culture also influences her health can be really helpful to help create change conversations with the patient, but also to support that patient by being an advocate with the provider. So going back to that individual and saying, okay, here's what I know. Let's talk a little bit about our culture and how that's influencing and how we can work, you know, how we can integrate and be respectful of her culture, but also provide her with helpful information so she can make changes to better in this case, control that diabetes that fits within her and her family system. So I think you both hit on some really great points. I'm going to move to the next slide, but I have another case if we have time, just for time purposes. But really, really great points of bringing in both the physical, the psychological with her stress, her anxiety, her depression, the social with her family dynamics, but also the spiritual of how she makes meaning related to her health and bringing in her culture as well. All right, so I have a couple of questions for you all. In your own practices, whether you're in internship or maybe some of your former experiences, or maybe as you think about cases, how do you see using the BPSS approach? Or maybe do you have a case right now that without divulging private information that you feel like this could be really helpful with or really fits for their current experience?
I do have a client right now. I have a 35-year-old female that presented with her partner. He is in his 60s, and they presented originally for couple therapy. However, she has a whole lot of trauma to unpack before we could really even get into the trauma work or get into the couple work.
Sure.
And her current diagnoses came from psychiatry. So she has kind of a lengthy history. Schizoaffective disorder and dissociative identity disorder were her two biggest things. And then there were a lot of relational pieces that go with that, from just attachment stuff stemming from her childhood and with her partner.
Yeah.
So I have been in contact with a pharmacist to consult on her case. I've been in contact with her psychiatrist, and I've also tried to contact her individual therapist to consult
That's
on
awesome.
the case as well. We've really had to take a deep dive into her cultural practices and what they mean to her and how she can still make them relevant in her life today, because she is also Native American
Yep.
and she comes from a military culture as well. Her father was in the military.
Yeah. Yeah, that's a great example of really looking at things through all of those lenses, right? I think that and using that collaborative nature that we have as MFTs to not be afraid and say, these are things I don't know a lot about, right? So I need someone who's a little more well informed about the medications, or her psychiatrist that maybe could help consult. Sometimes I think not just MFT, but sometimes as professionals, we may feel like we have to kind of stay in our box a little bit. And I think this is a great example, Megan. You create a great example here of how to push into some of that discomfort and collaborate to know more and to create change for that client. That's a great example. Great example. You also highlight, I think, trauma is one of those that I already used that as an example that really fits with biopsychosocial spiritual, right? Because it impacts physical, psychosocial. It also impacts how they see the world around them. It impacts safety. It impacts relationships. So I think all of that is very relevant for that. Absolutely. Another example that I'll share that I think that you all may see a lot is with chronic pain. With chronic pain, there's a huge, I explain this to clients and patients that says chronic pain is one of those that it kind of has two sides here, right? It has the physical pain, but there is a huge emotional pain that comes with chronic pain. And so being able to really lean into that and learn about the bio piece of it as well, and how that impacts both the psychosocial and the spiritual well-being as well. Other examples of a case that it might be helpful to use this lens?
Sol, do you want to come off mute? That's a really good example. that you
Yes,
put in
thank
the
you,
chat.
Dr. Bayman. Yeah, I was just commenting about clients that have autoimmune diseases.
Beautiful example.
Seeing a lot of them lately, and the fatigue, the chronic pain, the crisis, like managing symptoms and family support, finding a plan for them. I've also have to do some research on different, because diseases that I had never even heard of.
Yeah.
So I think this would be a great fit for them.
Great. That's a great example. And I think you make a great point, so that, it's things that maybe, again, we didn't go to school necessarily to learn about autoimmune diseases, but then to really see the systemic impact of that particular experience is huge, right? Because those are very misunderstood. They're very hard to diagnose. It leads to a lot of emotional and physical toll on your client, certainly going to impact relationships. So there's a lot of different pieces. That's a beautiful example. And honestly, you could probably argue, and hopefully that I've made my claim, that really the biopsychosocial spiritual framework can be applied to any case, right? When you think about, as you've all mentioned some examples, but even anxiety, we've mentioned, sexual desires or intimacy, there's a biopsychosocial spiritual piece to that. Disordered eating, neurodiversity, body image, right? There's really aspects of biopsychosocial spiritual pieces within all of that. So hopefully you have gained a couple of pieces of that you all can take as you move forward and applying with your own patients and clients. There's a few kind of reflective thoughts here on this screen, but for now I want to just pause because I know we only have a couple minutes left to see if there's any questions for me about MedFT that I can be helpful with before we wrap up today.
Is there a specific training to be a MedFT? Like, I know you said it's us MFTs, but how can we get trained on that?
Yeah, it's a great question. So, as I mentioned, the license is still right. You still would be a licensed marriage and family therapist. So there are some trainings even through AAMFT. Let me skip to another slide here. That there's a topical interest group. Now it does cost a little bit more than your typical student membership to join. But this can be a really great resource if this is something you're interested in. Now, there's not necessarily, you can go on and get formal training, right? You can get an whole nother degree or certification, but you don't have to. I know a lot of you could be doing this work now, right? Whether it's working in a healthcare system or working in your own practice and applying this lens. But there's a lot of resources out there. This is a really great kind of one-stop shop to see like what are some of the books, the articles, and I should have listed some of those on here that can be helpful, but AAMFT often will have little webinars or some trainings that you can join to just learn more about this work. Or there's also even at the national conference that happens every year, the annual conference, there often are different workshops that you can attend just to learn a little bit more about how to apply this approach. But I encourage you, if healthcare is kind of something you're thinking about when looking for jobs, it may not say MedFT. Now, some are adapting that language, but it might just say a marriage and family therapist or a behavioral health provider, a behavioral health consultant within a healthcare system. So looking at the training and the licensure that they ask for, some may even say a licensed clinical social worker, because that has a huge roots in medicine as well. But doesn't mean that you can advocate and say, this is my training as a marriage and family therapist. And now that we've had a lot of changes in medicine with billing, now as MFTs we can bill for Medicare, that's made a huge difference for MFTs working in healthcare systems and like VA systems. So that can be another great kind of resource. So when you're looking for jobs or internship sites, look in medicine if there's some things. It's becoming more and more of a thing. So I think there could be some great opportunities if interested.
Yeah, I just wanted to add two examples. I have a Capella intern right now who came into the MFT program. His wife was diagnosed with cancer, and it changed their relationship so much. And he was so interested in this that he went in to become, so he is very interested in interning at a hospital, working with couples who a person has gotten a diagnosis, a cancer diagnosis. I also had an intern years ago who worked in an oncology team. She was the family therapist on a pediatric oncology team where a child got a diagnosis, cancer diagnosis, and she worked with the family, the siblings. Like now, one of the siblings got a lot more attention, and mom and dad were, really, consumed with healthcare for the child. What about the other kids in the system? So there's just so much opportunity, I think, and such interest that we really do have the skills and the systemic approach that is so.
Like you mentioned there, anytime there's anything that pops up, that system's perspective, it can't help but change the system that they're interfacing with. So I think that we are just really uniquely skilled to do this work. And there's definitely a need. Honestly, every healthcare system that I've gone to, they're constantly throwing patients and clients because they see us as the experts in relationships, and we are. And so you're an asset to those systems as well, that they went to med school. They didn't train in couples therapy. They need support and they want your support. So, I hope that's something you'll look into. If this is an area of interest, for sure. I did put my email, in the chat. So if you ever have questions or ever want to follow up on anything, I'm always willing to connect.